Assalamualaikum. Can you all hear me? Assalamualaikum and very good morning. My name is Dr. Amin. So I was invited in your prime session today. So I think if you're ready to present, you can just start.
Okay. Bismillahirrahmanirrahim. Thank you, Doctor. Can everyone hear my voice? Am I audible?
Yes, please proceed.
Yes. All right. So, Bismillahirrahmanirrahim. Alhamdulillah rabbil alamin wa bihi nasta'in ala umuri dunya wa din. Wassalatu wassalamu ala rasulil amin wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So, Alhamdulillah, first I'd like to thank Dr. Aminuddin for attending our prime today. And inshallah, today we'll be discussing about prime. In prime, we will be discussing about stroke. So we'll go to introduction and then go to the bit of classification and then clinical approach and go until the management, inshallah. So let's first go to introduction. First, we need to define first what does it mean by stroke or cerebrovascular accident. Is an abrupt onset of neurologic deficit that is treatable for focal cerebral be it infarction or hemorrhage, many vascular causes. In Malaysia, based on Malaysian National Burden of Disease study in 2000, recorded that second leading causes of death in Malaysia due to stroke, and the prevalence based on National Health and Mobility Survey is 0.3% among Malaysians. And it is the third leading cause of death worldwide, and also the leading cause of disability worldwide. So the mean age of onset was older age between 41.5 years old, plus minus 8.8, or so it can be between 30 to 50 years old, or less than 65 years, usually the onset of the stroke. So the sex ratio of male to female is 1.4 to 1 ratio. Male are more commonly affected, but to 0.4 ratio. So the classification can be divided into vascular system, mainly arterial venous. 99% of the cases are arterial, and further divided into the pathology, be it infarct or hemorrhage. So for the infarct and hemorrhage, for the infarct can be further divided into whether it's affecting the arterial circulation or posterior circulation, depending on site of lesion. And for the hemorrhage, can be intracerebral, or known as brain parenchyma hemorrhage, or subarachnoid space, where it can both of it will cause increased intracranial pressure, whereas the brain parenchyma, it can be space occupying lesion. For the clinical classification, we can use Benford stroke classification, where it will specify how severe the stroke affecting the anterior posterior circulation, or also can be occurred as lacuna syndrome, where the small portion of brain affected. So each classification will have its own criteria indicating which classification it's adhered on. So for the common pathophysiology, it will be discussed further next presentation. So this classification is mainly for us to the localized or the pathology of the stroke. Right, for next is for the anatomy. Mainly we focus on how the circulation supply which part of the brain, because the part of the brain and the location of the site of the lesion will manifest it in the patient's presentation, be it anterior cerebral artery or medial cerebral artery or posterior cerebral artery. But usually for the anterior circulation, it will affect the internal carotid, also, and mainly it will also affect in the medial cerebral or anterior cerebral artery, and also can affect the ophthalmic cerebral artery. So it depends on where the circulation is. As for the posterior, it will affecting, or also known as vertebrobasilar artery, can be affecting the brainstem, lateral medullary, cerebellar, or basilar artery. So this supply of the location of the brain will indicate which part of the brain or how the patient will be presented. So the pathophysiology can be further understood into two. One is ischemic stroke, accounted for almost 85% of cases, whereas hemorrhagic stroke accounted for 10%. However, hemorrhagic stroke have high mortality rate of 50% risk of mortality when the patient have hemorrhagic stroke. For ischemic stroke, it can be due to thrombosis, where the thrombus or atherosclerotic formation within the vessels, causing occlusion and hypofuse, leading to ischemia of the brain tissue, whereas the embolism can be, for example, coming from the heart and cardiac emboli, that lead to also occlusion and hypofuse and untimely cell death. For the hemorrhagic stroke, can be intracerebral and parenchymal, due to blood vessel structure and cause abnormal accumulation of blood within the brain. As mentioned before, it will cause space occupying lesions and also can deteriorate into further complications. Whereas subarachnoid hemorrhage is blood accumulation in the subarachnoid space of the brain due to head injury or cerebral aneurysm or arteriovenous malformation. So the risk factors and differential diagnosis. So the risk factors, the principal risk factors is that for stroke is similar to those of atherosclerosis. As for the causes of stroke, for the ischemic stroke due to atherothromboembolism, 50% of cases, and intracranial small vessel disease, penetrating artery disease, and cardiogenic embolism. For hemorrhagic stroke, can be due to uncontrolled high BP, overtreatment with anticoagulant, which predispose patient to susceptible to bleeding, which impact the coagulation pathway of the patient, and also due to trauma or common subarachnoid hemorrhage, cerebral amyloid angiopathy, ischemic stroke leading to hemorrhage, and arteriovenous malformation. As for the risk factors of stroke, further divided into non-modifiable and modifiable. The non-modifiable is demographic data like age, sex, ethnicity, where commonly in Asian, Black, African, and also Caucasian races, whereas the family history of stroke will increase the risk of the patient to develop stroke. As for the modifiable, most of the comorbidities, also lifestyle of the patient, that can be managed or can be controlled actually. Next is the differential diagnosis. The differential diagnosis are mainly focusing on neurological, due to the patient presentation is neurological deficit. So the differential diagnosis more pointing towards what can cause neuropathic or neurogenic symptoms like metabolic toxic encephalopathy due to hypoglycemia, non-ketotic hypoglycemia, Wernicke-Korsakoff syndrome, drug intoxication, etc. So epileptic seizures, hemiplegic migraine, structural intracranial lesions, encephalitis, traumatic head injury, hypertensive encephalopathy, relapsing multiple sclerosis, which affecting the central nervous system, conversion disorders, hyperviscosity syndrome, and peripheral nerve lesions. Because the patient presented with weaknesses can be due to upper motor neuron lesion or lower motor neuron lesions. For the clinical approach, as usual, we focus on the history and also clinical examination. For the history, first identify the chief complaint, and more importantly, is for us to know the time of the complaint, because that will help us or give us idea on how to manage the patient, the time and also the progression of the symptoms. And then after the chief complaint obtained, then proceed with associated symptoms. Mainly, it can help us to localize which part of the brain are affected. So we ask about speech disturbance, dysarthria or dysphasia or aphasia. Facial asymmetry, sometimes the patient will notice, or sometimes the family members will notice that. Visual disturbance like homonymous hemianopia, or even blurry vision, sensory impairment like tactile agnosia or asterognosis, altered sensorium, bladder dysfunction that can lead to urinary incontinence, headache, or signs of meningism like stiffness or photophobia. As for the risk factors of stroke, the medical history is very important. to know how control the hypertension, diabetes, dyslipidemia, and for the hypercoagulability disorder, or patient is on anticoagulant. Exclude other causes. Mainly, we need to exclude be it traumatic or due to other causes. Complication is mainly we want to know the severity of the condition, which may affect other systems, or the brain severely hyperperfused. So the clinical features of stroke, it will depending in which vessels or circulation are affected. For example, middle cerebral artery, aphasia, paralysis, you can read later on. Basically, if we know which part of the brain is supplied by the vessels, then we will have the idea of how the presentation based on the, everyone have seen the homunculus, right? So that part of the idea, parietal lobe dysfunction. So this one is middle cerebral artery. As for the anterior cerebral artery, mainly weakness of lower limbs more than the upper limbs. As for the posterior, mainly vertebral-basilar artery, since it's supply the brainstem, some cerebellum. So patient can also present it with cerebellar signs, hemiparesis or hemisensory loss, contralateral cranial nerve palsy, or homonymous hemianopia, cortical blindness, since it supply the occipital lobe, which mainly the visual cortex. So the physical examination, the main idea is for the physical findings, outward functions, for the limb weakness, speech, and gait problems. As for the risk factor, and also the risk factor like the heart murmur, for example, or abnormal heart rate or AFib, possible complications are also during the examination should be anticipated. So during the examination, we need to look for the general appearance, whether the patient oriented in place or not, the conscious level, and then upper and lower limb examination in the tone, power, and reflex, and then cranial examination, cerebellar signs, and other neurological examination that need to be attended or conducted on the patient. And other systems to assess for complications from the condition, from the stroke, or even the risk factor or the causes of the stroke incidents. These are the we go for the general appearance, surrounding, look for the walking aid, feeding tube, lines, catheter, skin for xanthelasma, for patients who have dyslipidemia or cholesterol disorder, lipid disorder. Eye, arcus senilis, another system to complete with CVS, murmur, respiratory infection, distended bladder, cranial examination, motor system. This one, to be fair, that when there's a patient is at early stage of stroke, patient will have hypotonia and hyporeflexia. However, when it subsequently it will become hypertonic and also hyperreflexia. As for the sensory system, this one can be assessed also for the pinprick and also proprioceptions. As for the gait and also other cerebral assessment like finger nose test, dysdiadokinesia, heel shin test, rhomboid signs, and heel tooth walking. And for the complication, I would like to invite Ibrahim Zaki to proceed with the next part.
So for the next part, we will proceed with the complications of stroke. So the first complication is cerebral edema. This is due to endothelial dysfunction of the capillaries. The stroke patient will be treated with IV mannitol. And next is seizure. However, this is rare. Usually we treat this patient with short-acting anticonvulsant agent. Next is delirium. Delirium patient is associated with poor outcome and longer hospital stay. So we screen the patient by using 84 score, 480 score. Next is fall events, which is common in stroke patient. This will result in serious injuries such as fractures. Next is infection. The common one is aspiration pneumonia and also urinary tract infection due to urinary catheter. Patient will be treated with antibiotic therapy. Next is pressure sore. This is as a result of bed fast stroke patient. So in order to determine the risk of pressure sore, usually we perform Braden scale. Next is deep vein thrombosis as a result of immobilization. The last two complications due to reperfusion therapy by Acute. So Acute can lead to bleeding and also angioedema, specifically orolingual angioedema, which can lead to airway destruction. Next slide. Next slide. Modified ranking scale to determine the risk of fall, and also Braden scale to predict the pressure sores. Next slide. So for the investigations need to be done in order to confirm the diagnosis and also to determine the mechanism of strokes, whether it is ischemic or hemorrhagic. Investigation is also done in order to stratify risk and prognosis, and also to identify and treat underlying causes which lead to stroke. So first we can do blood investigation, such as full blood count, to find anemia, polycythemia, which is a modifiable risk factor for stroke, thrombocytosis or thrombocytopenia, random blood sugar, random blood glucose, to find hypoglycemia, which also can lead to stroke mimic or hyperglycemia, renal function test, coagulation profile to rule out coagulopathy, lipid profile to find whether there's dyslipidemia, which is a risk factor for stroke. Next. Some of the optimal blood tests that can be done in certain patients, such as serum SR and CRP, look for any sign of infection, BDRL in syphilis infection, whereby in untreated syphilis infection can lead to neurosyphilis, which can lead to stroke, autoimmune screening, thrombophilia screening, homocysteine, whereby hyperhomocystinuria can lead to stroke. For ECG, need to be done in order to rule out any cardioembolic cause, such as atrial fibrillation. Imaging, such as CT brain, in order to know whether it is hemorrhagic or ischemic stroke, and also to rule out any ischemic stroke mimics. Chest radiograph to determine the cardiac or pulmonary cause of stroke. Next. So this is CT scan of brain. Ischemic stroke is characterized by hypodense lesion, and hemorrhagic stroke is characterized by hyperdense lesion. Other imaging that can be done include echocardiography, CT angiogram, and contrast angiogram to assess the circulation, MR angiography, and also MR venography. So for the management, for acute general management, the aim is to provide supportive care and treat acute complications. So oxygen and airway oxygen and airway support, oxygen saturation should be should be maintained above 95%. If it's below, the patient should be given with oxygen. BP lowering usually is indicated in patients with comorbid such as heart failure, aortic dissection, eclampsia or preeclampsia. Usually if the blood pressure is less than 220 over 120 millimeter mercury, we won't give patient with antihypertensive. Some of the antihypertensive agents that we can give include captopril, labetalol. However, nifedipine should be avoided because it can lead to drastic decrease in blood pressure. Blood glucose control should be maintained between 6 to 10 mmol per liter. And also we need to avoid hypoglycemia. Nutrition is important so that the patient can become well. Fever control we can give with antipyretic, infection control can be treated with antibiotic therapy. Patient with stroke should be assessed whether the patient has urinary incontinence or fecal incontinence or constipation. Urinary catheter should be avoided because risk of urinary tract infection. Tinaship maybe can be considered in male patient. Mobilization in order to avoid complication. However, excessive mobilization within 24 hours should be avoided. To treat increase in intracranial pressure can be treated with mannitol hyperventilation. If the patient has hydrocephalus, we can manage the patient with intraventricular catheter, deep vein thrombosis prophylaxis, such as intermittent pneumatic pressure, and also heparin. And lastly, to treat seizure, we give with short-acting anticonvulsant agent. Next slide. So the key treatment in ischemic stroke is reperfusion therapy. So in intravenous thrombolysis, we will give the patient with recombinant tissue plasminogen activator such as alteplase. So when we will give alteplase usually will be given when the onset of stroke is within 4.5 hours from the onset. Or the treatment window can be extended if in CT perfusion there is up to can be extended to up to 9 hours if the CT perfusion there is focal penumbra mismatch, whereby indicate low risk of hemorrhage and also high rate of the patient can be treated well. And also if the onset is unknown, we can provide the patient with IVT if MRI there's evidence of I'm sorry, I forgot, but if there's evidence, MRI shows that we can provide the patient with intravenous thrombolysis. Other than antiplase, we can give tenitaplase if there is no antiplase available. Tenitaplase can also be given if acute stroke is presented within 4.5 hours with evidence of large vessel occlusion, such as in proximal middle cerebral artery and also internal carotid artery. Next slide. Other than that, we can manage the patient with endovascular thrombectomy. In this management, we remove the occlusion, the thrombus in the vessel. First is hyperacute endovascular thrombectomy, which is usually we give the patient this treatment when the onset is within 6 hours with evidence of large vessel occlusion, such as in, like I said, in proximal middle cerebral artery and also internal carotid artery. Or if the treatment window can also be extended if CT, MRI perfusion shows clinical radiological mismatch. In this patient, we can give the EVT within 34 hours from the onset. Other than that, drip and ship management where IVT is given prior to EVT. And the onset is within 4.5 hours and there should not be delay in proceeding to EVT. Next slide. So the prognosis depend on the type of stroke, size and location of lesion. Hemorrhagic stroke has higher mortality than ischemic stroke. However, it has a better neurological and functional recovery. Brainstem infarction, large hemispheric infarction and cardioembolic stroke carry a poor prognosis, while lacuna infarct has the lowest mortality rate. Next slide. So if the patient survives the first 30 days after first ever stroke, he has annual death risk of 10%, Usually, if the patient died within the first 30 days, usually due to the effect of the brain damage. If after 30 days, usually the mortality is due to complications of immobilization, such as bronchopneumonia, deep vein thrombosis, recurrent stroke, and also coronary heart disease. So, if the patient had been treated with antiplatelet drug previously, it will reduce the risk of death with about 50% in patients with ischemic stroke. Some of the risk factors for stroke mortality are old age, atrial fibrillation, ischemic heart disease, diabetes mellitus. For the recurrent rates are 4% in the first month, 12% in the first year, 30% by 5 years, and up to 40% by 10 years. And the risk for recurrent stroke is higher in patients with cardiovascular risk factors, symptomatic atherosclerotic disease, active source of thrombosis, or patient who discontinued their antiplatelet and antihypertensive therapies. So about 1/3 of stroke survivors has permanent disability after the first episode of stroke. 58% of patients will survive the first stroke, will regain independence in the activities of daily activity. The progress time is actually determine the functional recovery of the patient. Within the 2 months, the first 2 months of stroke patient, they have greater recovery. But after 6 months, they have less likely percentage to recover the renal function. Other predictors of disability are older age, very low premorbid level of activities before stroke, and subsequent recurrent stroke. That's all from Q4 listening.
Okay, so thank you for presenting for Aziz and Ibrahim. I think that's a very precise and short presentation on stroke. I think it covers almost overall of stroke. Okay, I'm sure all of you have gone through this topic before. I think in year 3 also you have a seminar on stroke, and then again in year 5. So I just wanted to highlight a few things. Stroke is common in the medical ward. It's very common presentation, and I'm sure all of you, once you become a houseman later, you will definitely encounter stroke cases. Okay, either in emergency or in medical ward. All right. So I think in the first slide presented by Aziz just now, there's like a table on how you can classify stroke. Okay, the thing with stroke is there are a lot of ways how you can classify it, and sometimes it can be very confusing. Yes, that's like, okay, the classification bit. Okay, but according to our latest guideline, I think in Malaysian guideline in 2020, they suggested for easier ways of if you want to classify, you can divide it into 3 groups, either clinical. Okay, the other one I think is the etiology. Okay, and the other one is I think site of lesion. But I think it's site of lesion if I'm not mistaken. We can double check on that later. Okay, but the things that I wanted to highlight in terms of knowledge on stroke and also practicality, you need to really understand and practice this clinical classification, because when you encounter the patient, sometimes you don't have the imaging yet, okay, with you, or maybe you have the first image of the CT brain, which with no report and no other imaging. So you have to determine what is your findings in your clinical findings, and this is also what will be assessed, I think, in your exam, on how you can identify what are the neurological deficits that will be present in a patient who comes in with stroke. Okay, so you have to at least practice and perform neurology examination And I think with stroke patient, it's the best type of patients where you want to practice your neurological examination. Okay. Then after you have examined thoroughly, you have to decide how you want to present your findings as well. This is another important thing. Okay. When you want to present your findings, you have to have a logical approach and also not contradicting each other. Okay, for example, if you find out that this patient has a stroke, it will be most likely upper motor neuron lesion. Okay, so you would expect in your findings all the upper motor neuron signs. Okay, if during your examination you found that the patient has, for example, lower motor neuron sign, then you have to think of other things or maybe re-examine the patient again. Okay, that is a part or advice on the, I think, on the clinical bit. Okay, and then especially in final pro later, you will have to perform. I think it's a modified long case, so you have to perform in front of the examiner. Yeah, sometimes they have two examiner and they are very senior. Sometimes it can be a bit intimidating. But if you have done it many times, I'm sure there's no problem performing in front of the examiner. Okay, just be confident with what you know and just perform it systematically. And I don't think anything can go wrong with that. Okay. Other things, usually in I've just spoken about the clinical, so I just mentioned usually in we won't sometimes we are trying to be a bit tricky. We won't give you a straightforward case if we want to give you a stroke patient. One of the tricky patients that sometimes given to students is someone who presents with posterior infarct with cerebellar signs. So there are no obvious, hemiparesis, for example. So sometimes if you miss your cerebellar examination, for example, you think that this patient has no impairment or no neurological deficit, whereas this patient has obvious cerebellar signs. Okay, so just make sure you don't miss all the steps like what I mentioned. Okay, and don't miss if the patient can walk, don't miss the gait examination as well. Okay. Otherwise, during your practice later as a doctor, you also need to, review the patient with stroke daily in the ward. And when the consultant or neurologist round, they want to hear your presentation and they want to know what is the etiologic, etiologic causes of the stroke. Okay. So why? Because it will affect the management of how we would manage this patient. Okay, in terms of etiologic, I think it was mentioned by Aziz just now, but I think to make it easier, you can classify it into three main things, three main etiology, which is large vessel, okay, second is small vessel, and third is embolism. Okay, so if you can identify which type of etiologic this stroke might be, then you can decide on what investigation, further investigation that you need to be doing while reviewing the patient in ward, because you need to understand sometimes when you've seen a lot of stroke, you just take things for granted and then just treat all the the possibility of complication of patient who had already had the stroke, but you miss the major etiology, for example embolism, for example, like large vessel, where they have intervention that you need to do before another stroke comes again. Okay, if it is a small vessel, then nothing can be done apart from controlling the risk factor. But if it is an embolism that causing the stroke or large vessel, then you need to address the underlying factors as soon as possible. That's why it is important to identify it early. All right. Okay. In terms of your presentation just now, I think I would like to add if you have heard about NIHSS score. Have you heard about that? National Health of Institute of Stroke Scale, NIHSS. That is the other scoring that is commonly being brought up, especially nowadays when we have advancement in the treatment of stroke, which is which is thrombolysis, and endothrombectomy, just mentioned by Ibrahim just now. So later on, you look there's a calculator, there's apps on NIHSS score. Later you read more about that, okay, and make sure you know about it, okay. I don't think it will come up in your exam with NIHSS score, but it will definitely comes up when you work as a doctor later. And if you want to, interested in stroke, then it will be more significant in that, okay. Stroke mortality has been improving in the years because we managed to control the risk factors, okay, among patients. And the other one is because we improve in our stroke unit, okay, stroke care, okay. And in terms of advancement of technology, more and more thrombolysis centers are being brought up, okay. UIA, SUSMEC, not yet, because we just have one neurologist at the moment. We hope to have more neurologists later on. But the centers that I did my attachment before was in UKM. They have a stroke call. It's just like cardio call. It's like MI call, okay, but instead it is a stroke call. Meaning, if a patient presented with stroke, it needs to be assessed by a neurology team within half an hour from ED, okay, and then they need to decide whether they want to call for a stroke protocol or not, okay. Then once they call for a stroke protocol, the patient will be sent straight away to the radiology department, and they will do all the CT scan, not just a CT brain, but also like what Ibrahim mentioned just now, CT brain and CT perfusion, and sometimes they would proceed with MRI as well, okay. Dewey flare MRI. But usually after they do the CT perfusion and MRI, after they review the plane, of course, because if it is a hemorrhagic, then they would not proceed with other scan, okay. The idea of the extra scan that you mentioned just now, Ibrahim, I noted that you're not familiar with that. I'm sure it is quite new to all of you in terms of MR angiography, and also CT perfusion. It is also new to us as well, to the medical doctors as well in general, because all of this is advancements of technology, and it depends on where you practice, where in terms of the availability of this technology, okay, in the radio department. So what we are looking for in terms of CT perfusion and MRI Dewey flare, if we want to look at the penumbra area, okay, have you heard about penumbra? So penumbra area is where area of the brain where they got a lack of blood supply due to the stroke, but they still alive. Okay, they're still alive and they can be revived if you can, correct you can give back the blood flow to that area. So that are the area that we want to save, okay, and that's how the CT perfusion and MRI Dewey flare plays a role. So if you look at the CT perfusion scan and you can see the penumbra area is viable, then you can extend. In terms of this one, is mentioned that up to 9 hours you can still give altiplace, and then hopefully it will save the penumbra area. But like I said, it is not available yet in SUSMEC, so we don't have a stroke protocol yet, okay, but hopefully we can have later on, okay. In terms of, okay, going back to your exam questions, usually, okay, you still have true false question, right, in your final pro. I think you have quite a similar format, true false, and then OBA, right, and then PMP. So if they want to give you stroke topic for true false, what you need to know in true false is that you have to know the overall, like this slide I think is quite enough. Or they can ask you true false question about something about maybe like posterior stroke, or maybe they want to ask about anterior stroke. Then you have to know, the choice of answer of true false will go through all the pathophysiology, the clinical findings, the imaging, the treatment, if you can understand what I'm trying to say. So all of that will cover all the things about for example, about the anterior stroke just now. That is for true false. So as long as you have overall knowledge of stroke, I think true false would not be a problem with you lah, answering the true false question. For OBA question, usually it's about locating where is the stroke. Okay, they will give you a clinical scenario. We will give you a clinical scenario saying the patient present with specific symptoms, specific neurological deficit involving the cranial nerve and also the upper limb and lower limb, and you have to identify where part of area of the brain that's causing the symptoms. Okay, this is OBA question. It can be tough, but I think you need to go through your neuroanatomy again to understand or to at least get some idea which part of the brain causing what kind of clinical presentation. Okay, because like you mentioned before, the prognosis in brainstem stroke is very severe and very poor prognosis. So you need to know where is the brainstem. Okay, what are the regions, anatomy, location in the brainstem. So you need to know that in quite detail as well. Okay, to answer OBA. All right. So for PMP question, we won't give you if a stroke question comes out, we won't give you straightforward questions on stroke. Okay, we would combine stroke question with other condition. For example, we want to do cardioembolic stroke. So we would give you a patient who is a drug abuser who has also infective endocarditis, but presented with the stroke symptoms. So it won't just be a straightforward stroke, stroke condition. So, but your question it will be standard workup, but you have to also consider the other background that we give you. For example, if the patient comes in with fever, new cardiac murmur, okay, and presented with a hemiparesis, then the question would be, what is your impression? Maybe you want impression on the hemiparesis first. Then you mention about the hemiparesis. Then what are the investigation? Then you put all the investigation for the stroke and also for the possibility of IE as well. Okay, so as long as you can list that, and you have to be more like open-minded in terms of other condition, comorbidity can occur as well, then I think you should be fine into answering that type of question. Okay, because I think final pro and year 5 we won't give you straightforward question for like year 3. The other things that can come up is young stroke. Okay, young stroke, because it's been coming trend now that stroke patients coming younger and younger in age, and I think Aziz mentioned just now the average age also is 40 plus according to our study in Malaysia. So it's very young to have a stroke. So you need to know what are the workup for young stroke, because this will be asked in your for example PMP question. I think Ibrahim mentioned just now as well about the additional blood tests. Okay, especially the autoimmune screening, what are the types of autoimmune blood tests that you need to send, okay, and what are the other bloods that you need to do lah. All right. I think as long as you can think in a logical way, I think that will be okay in terms of answering that kind of question. But you need to have knowledge as well in terms of young stroke, because it's very specific in terms of investigation, what you need to be sent. Okay. All right. Okay, I think overall quite okay. In terms of the question, just like what I mentioned, is there any other specific question that you guys want to ask me? If you want to ask, if you have any question, you can ask me. Okay, the chat box, hemorrhagic stroke, any certain criteria to select which patient that needs to go for surgical intervention? I think that one will go under neurosurgical, not medical. Okay, we won't ask you about hemorrhagic stroke. Definitely not in medical question. But I think it's more surgical, neurosurgical. Any other questions? But sometimes in clinical setting, sometimes you can be asked, how can you differentiate between in clinical setting when you examine the patient, whether this is a hemorrhagic or this is a ischemic, but you can never tell in terms of clinical examination alone. But there are signs of, raised intracranial pressure, things like that can indicate it's a hemorrhagic rather than ischemic. Any other things? Any other question?
Assalamualaikum, Doctor.
Assalam.
So just now, Doctor mentioned that the trend of stroke is going more towards the younger patient. So is there any additional risk factors for them, or any other? Is it the same pathophysiology?
Okay. I haven't encountered any study that specify, new risk factor or different risk factor compared to the older generation, why they are having. But I think maybe because they are having more of this risk factor because of lifestyle changes in the population and in general. Because previously, maybe the generation before them, maybe they are more, less access to food, okay, less access to unhealthy food, okay. So more physical activity that they're doing, so they automatically will reduce their risk factors. But as our generation comes in, they will have more, relaxed lifestyle, okay, with plenty of, food. So that's why they increase all the risk factors. And again, like I said, the most likely because of the risk factors that causing the stroke. But again, previously we might underdiagnose previous generations of young stroke. Okay, we might not have the technology, the blood tests that we are doing now. So that's why we are sending all these blood tests to determine whether this is actually underlying like congenital or underlying other disease causing the stroke, or it's just a typical risk factors that causing the stroke. But there's no study to identify to say that there's a specific things in young rather than old.
Understood. Thank you very much, Doctor.
Okay. So I hope every one of you has examined a patient with stroke in the ward, because we have plenty of patients come in and out from the ward. But for me, I don't keep my stroke patients that long in the ward, so I will optimally 3 to 5 days before I discharge, okay, to avoid other complications in the ward. But when you see this kind of patient, you need to practice examine them, okay, because that will help you a lot in terms of your final pro later if you get a stroke patient, okay. And you have to you have to think like the examiner lah. If the patient is too bed bound, they won't call that kind of patient in your final pro. They will call a patient who is slightly hemiparesis, who can still mobilize, okay, with stick, and then you have to identify that kind of neurological deficit. Okay, any other specific questions that you're not sure about stroke?
Doctor. So the let's say for the final diagnosis, do we specify this based on classification like stroke secondary to medial cerebral artery infarct atau thrombus ke apa ke? Is it like or just cakap stroke je macam?
Okay. If you have examined the patient, if you have clocked the patient, for example, this is like a modified non-case. If you have clocked the patient and you have examined the patient, then you can mention about this classification. Okay, you can mention anything. It's better if you mention this criteria, this classification. But actually it's the way how you present. If you are very confident, this is one of the group. For example, this is most commonly is lacuna syndrome lah, most common. Okay, but if they met all the three criteria for total anterior for touchy, then you can mention about that as well. Okay, but the way how you can present is you can say that okay, my impression, my provisional diagnosis is this is a case of a ischemic stroke, most likely classified in the group of lacuna syndrome. You can say something like that, rather than you just say like my provisional diagnosis is lacuna syndrome stroke. Okay, so you just mention it first. This is, you think this is a ischemic stroke, then your classification. Okay, why? Because if you are right, this is stroke, then you already get the marks already, but you're wrong in the classification. So the examiner will say, oh, you're right about the stroke, but you may be wrong about the classification. Okay, but if you present the classification straight away, then the answer could be just wrong lah. Okay, all right. Any other question? So I think in final, for your batch, you will also have, I think, 2 station, is it correct, for OSCE? Men OSCE? We just added that in because of post-COVID. Is that correct? Because previous batch, they only have modified long case. But I think you
Yes.
guys have, yes,
We have
2.
men and Menoski.
Yes, you have men OSCE as well, right? 2 men OSCE. Okay. Okay, question. If the patient has posterior circulation, in fact, treatment for them are similar to anterior. Are the investigation similar as well? Yes, similar. Treatment is similar. Investigation also similar, just to identify where is the lesion. The the concept is similar. It's just the area that is different. Because a different area, they present with different neurological deficit. Okay. Have you guys managed to examine a lot of gait, for example, like cerebellar gait and things like that? If you have the opportunity, try to find patient in ward. If not, you can just just Google and see all the videos that I have about the different in gait. Okay, especially in stroke gait, posture in stroke. Okay, so that you guys are more familiar about the stroke. Stroke itself is a very huge topic, and you can go very detailed. And but I think for what you have presented, I think it's quite enough at your level. As long as you can perform, like I mentioned just now, perform a thorough neurological examination, identify which classification, and then you can briefly mention about the relevant investigation and also the management. I think you should be doing fine. All right. But theory paper is always going to be tricky, and you have to think more lah. Okay, because we have when we design a theory question, we won't give you a one-step question. There's always two-step question. You understand what two-step question? For example, I want to give you a question on posterior stroke, or okay, maybe I want to give you on minor stroke or TIA. I won't mention the diagnosis, but I just give you a patient with presentation of TIA or minor stroke. Okay, but then the question is not about what is the diagnosis, but the question is about how would you manage this patient. Do you understand? So in that is a two-step question. So you have to read the TAM, get the diagnosis yourself, and then know what is the management of that diagnosis. Okay, without the one who written the question mention to you what is the diagnosis. Do you understand? For example, like in minor stroke, nowadays we have study that we give two antiplatelets, which is cardioprin and clopidogrel for 21 days. And then we stop one of them and continue with either clopidogrel or aspirin for lifelong. Okay, so if I want to ask you on that question, what is the management of minor stroke? Instead of I ask you straight question, I would give a STEM question of a patient who comes, with hemiparesis, but the NIHS score is low. Okay, that's why important you have to know what is the NIHS score. Okay, if it is low, then it's a minor stroke. Okay, then what is your management? So that's the question. For example, like in OBA question. So you have to know the diagnosis first after reading the STEM, and you have to know what's the management of the diagnosis. For example, okay, this is like a two-step question. Most of the question will be that kind of question. Okay, there are a few, one or two questions that will be direct question. Okay, because we have to mix easy and difficult questions in your paper. All right. So far, anyone encounter difficult stroke question, having difficulty examining stroke patient? No? Okay. Okay, I open again. If anyone has any question. If not, I think we can end the session and you can take some break before your next session. Any other last question? So when is your final pro again? Sorry, not familiar with your timetable.
November.
November. Okay. Okay. Still have got a lot of time. Okay. So if there's nothing, then okay, all the best for you. I hope you learned something today. If you have any further questions after this, before your exam or anything you want to ask me, you can just approach me. Okay. I will be in the ward, in the hospital. Okay. Or you can just text me lah. All right. Okay. Thank you, everyone. Okay. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Okay.
Assalamualaikum, Doctor. I think everyone is ready. We also have students that is joining from YouTube Live. So before that, we open our discussion today with Kita Al-Fatihah. So our topic for today is acute coronary syndrome. So doctor, you may start now. Thank you, doctor. Sorry, doctor. I think we couldn't hear your voice.
Hello, hello.
Yes.
You can hear my voice?
Yes, we can hear your voice.
Okay, I already sent my slide to Maman.
You want us to present it?
Hello, that's my slide, my slide. Can you open my slide?
Okay, sure. Sure, doctor.
Assalamualaikum. Hello. Can you hear me?
Yes, yes.
Okay. Actually, I have had one. I did a previous group, year 5. Actually, they presented to me a very good acute coronary syndrome. Okay. I think the best I have ever had listened by the student. Actually, I think it's about before they took the exam, professional exam. I think if you can borrow their slide, I don't know, because I'm trying to borrow their slide also. Okay, but I couldn't actually because they already graduated. Okay, yeah. Hello. Shall I start?
You can start now, doctor.
Okay, our topic today is about acute coronary syndrome. I think, as you know from the topics, yeah, acute coronary syndrome. Syndrome is a constellation of many disease under one roof and then become a syndrome. Okay. Can you next slide? Okay. So in this topic, we will discuss about how to diagnose unstable angina, non-STEMI, and STEMI. Yeah. Because in acute coronary syndrome, actually it's divided into 2 groups. Number 1, we call it unstable angina and non-STEMI. Another group is STEMI, some say STEMI, ST elevation myocardial infarction. Okay. Then if you talk about the myocardial infarction, actually, there will be 2 types. Actually, we discussed type 1 versus type 2. Okay, the type 1 actually basically is because of we know the pathophysiology, the cause is within the blood vessel. The type 2 myocardial infarction normally is secondary to the cause, for example, like anemia, sepsis, kind of thing, spasm. That also can cause features like in acute myocardial infarction. So the next we will discuss about STEMI equivalent, and then briefly probably we will discuss about the treatment in the emergency setting. Next. Okay. Actually, very important for us actually to differentiate between stable angina and acute coronary syndrome. What is stable angina? What is acute coronary syndrome? Actually, it is two different disease, two different pathology, even though the clinical features is the same. Why I say it is the same? Because both, yeah, if you have stable angina or unstable angina, stemma, acute coronary syndrome, both actually presents with chest pain. So, but the pathophysiology actually is different. Yeah, in stable angina, the pathophysiology is due to the atherosclerosis. Yeah, the blood vessel, yeah, getting thicker and thicker because the atheroma, yeah, then getting thicker and thicker. Even for example, like they totally occlude the blood vessel 100%, but the patient still has stable angina, which won't kill the patient. It's just the patient present with chest pain. I think up to now you understand, yeah? Hello?
Yeah.
Okay. The second thing is we are talking about acute coronary syndrome. Acute coronary syndrome is not because of it is because of the trauma, but the cap that cover the atherosclerosis, the cap that cover the sepsis is thin or get ruptured. You know, when the cap get ruptured, it stimulates the clotting mechanism cascade and eventually occlude the blood vessel. Okay, yeah. So the presentation of unstable angina and non-stemming and stemma, it depends on the degree of the blockage and the speed of the blockage, the block. Yeah. For example, like in the stemma, ST elevation mine, the clotting mechanism occurs actually very fast and totally occlude the blood vessel, which give to symptoms, cardiac enzyme, and also ECG changes. With in the unstable angina and non-stemma, it depends on the speed of the blockade. Yeah. If the speed of the blockade is in unstable angina and non-stemma, basically it won't occlude 100% the blood vessel. But because of the speed, meaning that because of the speed very fast, if the clotting mechanism occur too fast enough to give myocardial necrosis, the patient will present with non-stemma. But if the speed and the degree of the block is not severe enough, and yeah, the patient will present with unstable angina. Okay, I think you can see from the diagram, the cartoon here in the lumen, this is the atherosclerosis trauma. In stable angina, this trauma getting the atherosclerosis getting thicker and thicker and thicker, eventually occlude the blood vessel. It won't harm. It cause chest pain, reduce perfusion, and can cause heart failure also. Yeah, and that, yeah, but it won't kill the patient all of a sudden like that. By the case of acute coronary syndrome, because the plaque rupture here, you can see, and then promotes the clotting cascade within 10 minutes, either it close partially the blood vessel or totally occlude the blood vessel. Totally occlude, yeah. Total occlusion cause stemma, not total occlusion, unstable angina on stemma, but the difference between unstable angina and non-stemma, it depends on the speed of the blockage, the site, and also the degree of the block. Okay, next slide, please. Okay, so meaning that definition of unstable angina, again, the patient presents with chest pain. Both, actually, all the three present with chest pain. Yeah, unstable angina, normally the degree of chest pain is not too bad, sometimes 5 to 10 minutes, which occur all of the sudden. So how do you differentiate between stable angina and unstable angina? In the case of unstable angina, the chest pain occur all of the sudden. Yeah, suddenly the patient has chest pain. The patient actually was normal before, and then suddenly she presented with chest pain. And then or the chest pain, the patient has stable angina, for example, like, meaning that the pain always constant. Then suddenly the chest pain, one day the chest pain become more and more internal frequency, increase internal frequency, increase internal intensity, increase internal duration. those days, they said that if the chest pain occurs with this chest pain, actually labile chest pain occur within a month, and then we call it unstable angina. Less than more than 1 month, if the chest pain is constant more than 1 month, and it is called stable angina. Another thing is the chest pain after, for example, like post stenting, and then so post bypass surgery, and the first time chest pain also defined as unstable angina or non-stable. So stable angina, the chest pain is stable throughout, meaning the internal intensity, frequency, duration. Yeah, from those days, for example, like a month ago until today, the chest pain is the same. Then we call it stable angina. Stable angina caused by atrauma to acute kidney syndrome caused by plaque rupture or erosion or bleeding. Okay. Then how do you differentiate between stable angina and unstable angina or non-STEMI? So how differentiation is, number one, in stable angina, the chest pain is not that severe, not as severe as STEMI. Unstable angina, there's no ECG changes. In unstable angina, cardiac marker as troponin is normal. Non-STEMI, chest pain occurs suggestive or EMI, but the patient can present with unspecific chest pain, can be normal also, can has ST depression or inversion, yeah. But laboratory is showing release of troponin. This is very important, yeah, release of troponin. Whereas in the STEMI, yeah, STEMI, the patient actually has chest pain. ECG shows ST elevation, some changes. Sometimes they call in the acute, in the early phase of STEMI, the patient sometimes present with upper hyperacute T wave, and then cardiac enzyme also will be elevated normally after 2 hours. Okay, next slide. Hello, next slide. So this is a pathophysiology of atrauma in which occurs in most of us actually after the age of 30, because we have this fatty latent, yeah, within our blood vessel, eventually undergoing inflammation, or yeah, and then because of the epithelial injury, cause migration of monocyte and lipid eventually become a trauma. So the degree of this, the speed of this formation of a trauma, the degree of block actually is unknown, but it is probably most likely because of the lifestyle changes. If, for example, like if you are diabetic, you eat too much of fats, and then because of smoking also. Okay, this actually smoking and fat, of course, they cause the cap that cover the trauma is thin, which is prone to rupture. Okay, next slide. Okay, this is, for example, like we could solve it in the stable angina, it's a plaque formation. So, yeah, when in the case of unstable angina, you can see here because the plaque, yeah, the plaque that cover the atherosclerosis trauma is thin. And normally, not the thin one easily can get rupture. When they get rupture here, they promote the blood clots. And in case of STEMI, because the speed of the clotting mechanism is fast, and also the degree of the blockage is huge, and then this will cause ischemia, necrosis, some degree of necrosis to the myocardium, and then eventually elaborated the cardiac enzyme. This, in this case of STEMI, it will be a complete occlusion. Okay, next slide. So again, I want to repeat again because of this one. This is, we call it stable, the unstable angina. ECG can be maybe ST depression kind of thing, or maybe it's normal. But the most important is does not increase the biochemical marker. If they increase biochemical marker, we call it non-STEMI. Okay. But in the case of, for example, the partial occluded vessel, again, we call it unstable angina, partial occlusion, and non-STEMI in the case of if the biochemical marker is increased, yeah, is elevated. Okay, in the case of a STEMI, it will be total occlusion. This will again cause some ECG change. You can see here as the elevation here, Some patient has, for example, ST depression, then or definitely this will, because of the myocardial injury, there will be raise in cardiac biomarkers. Next slide. This is again actually, after business or AMI, again, the presentation, the working diagnosis, you do the ECG, the biochemical marker, then you get the diagnosis. The problem, the most important, the presentation is typical chest pain. Normally the chest pain about 5 to 15 minutes. It depends on degree of the block, the occur of the sudden, and if sometimes the block is huge, the patient can, the chest pain probably can be more than 30 minutes up to 15 minutes. Sometimes up to the 30 minutes in the case of ST elevation MRI. And then after that, you have to do ECG quickly within 10 minutes to make a diagnosis. From there, it depends, in the presentation, you have to decide whether this is unstable angina, non-STEMI, or STEMI. Next slide. So in the case of how they differentiate, I already discussed with you about the stable angina and unstable angina. Both actually present with chest pain, but then the nature of chest pain is different. The stable angina, the chest pain is similar as before. Unstable angina, the chest pain actually occurs first time, more intense, more in terms of frequency, intensity, and also duration. And probably, for example, post PCI, the patient has chest pain. The patient sometimes occur at rest, not really as usual with the GTM. This is actually most students actually made many mistakes about relief by GTM. Sometimes they ask the patient to put the GTM under the tongue, and after the pain relief after 10 minutes. And actually, the pain after 10 minutes relief is not due to the GTM, because the GTM, when you put under the tongue, it should be relieved within 10 seconds. If relieved within 10 minutes, it means that the chest pain release spontaneously. Okay? Okay, student, understood?
Yes, Doctor.
Yeah. Then sudden increase in frequency of the angina is also unstable, and also if the pain is duration of the chest pain is long, for example, like more than 20 minutes, most likely the patient unstable angina. So when you have the patient with acute unstable angina, or we call it acute kidney syndrome, you have to decide whether this patient is a case of unstable angina or non-STEMI or STEMI. How to differentiate? It depends on the ECG. ECG for unstable angina and stable angina is the same. It can be ST depression, but for the STEMI, it will be hyperacute tau T in the acute setting. And then in the first 2 hours. After 2 hours, then the patient can have ST elevation ECG. The biochemical marker also will be raised in the non-STEMI and STEMI. Okay? So far clear? Student?
Okay, Doctor.
Are you clear?
Clear, Doctor.
Yeah.
Yes, Doctor.
Okay, next slide, please. So the presentation again, okay, on acute kidney syndrome, the patient presents with chest pain. So then you have to describe, number one, the duration, the character, the nature. Normally, the chest pain occurs at the central chest pain, about 60% left-sided chest pain, about 5% on the right, sometimes at the epigastric area, sometimes also around the jaw. So the chest pain actually radiates. The chest pain radiates to the neck, to the jaw, to the teeth, and also to the left hand. Sometimes if the chest pain occurs in the epigastric area, it does not radiate to the hand, because the epigastric area normally the lesion normally occurs at the right side of right coronary artery. The left coronary artery normally present with retro chest pain at the left sternum. Okay, because of the blockage, sometimes the patient has acute shortness of breath, hypotension, syncope, and then nausea or vomiting. So when you inspect the patient look a bit, almost doom-like kind, pale, doom-like feeling, lung will be, for example, normal, can be in heart failure, yeah, yeah. And then it depends on the degree of the block and the timing when the patient actually come to you. Okay, next slide, please. So how do you evaluate diagnosis of STEMI? In this case, you have to do definitely traffic ECG. So you must make a conclusion, a diagnosis within 10 minutes. Yeah, ECG might not be seen early on the STEMI and need to perform serially every 15 minutes. But I don't advise to the serial ECG until you get the diagnosis. Yeah, the most important, you make a diagnosis within 10 minutes because you have to decide whether you want to do to go give lytic or not lytic. The difficulty is how to diagnose at the early part of STEMI. You know why? Because at that time, there's no ECG changes. Probably only the patient has tall T wave. And also another thing is cardiac biomarker at that time also negative. You know, because cardiac marker normally will be raised within after 2 hours from the onset of chest pain. So how do you diagnose? Sometimes you need echo. Then you see the echo when you see the akinetic movement of the myocardium, and then it is correlate very well to the ECG changes. For example, like your top wave like here, then you see this MI, then probably you can initiate lytic therapy very fast because as you know, yeah, in the case of STEMI, if you give lytic therapy within 1 hour, there will be 100% myocardial reversibility. So after 3 hours, then you are dealing with only 50 to 70% myocardial reversibility. So from this ECG evolution, you have to know this is normal, yeah. So when the patient come early, sometimes they have peak tall T like this, yeah. And then eventually it will evolve into ST elevation like that, yeah. This one and this one. Then after that, yeah, within 12 hours, you will see a Q wave. Q wave. Then this is after a week. Yeah, within a week, you get this T waves and slightly ST depression. But you can see here, you still can see here, this, yeah, the Q wave here, and then you can see the T inversion, meaning that the AMI occurs within a week. If, for example, like loss of T inversion with a Q wave here, normally the AMI already occurs after 1 or 2 weeks. Yeah, if no loss of T inversion here. Okay, and then to diagnose AMI also you need 2 contagious ECG. I think all you all know all the three clinical features of AMI. For example, like chest pain, ECG changes macro. You need 2 out of 3. From that, you know, the ECG, yeah, it must be 2 continuously, meaning V1 close to V2 or V2 close to V3 or 2 with a 3 or 2 with a AVF kind of thing. Yeah, it means that it's 2 continuous, meaning that if you do echo, the lesion is at the same side, meaning that V1 to V2, meaning that at that myocardium. It cannot be this myocardium and suddenly that myocardium. Then you cannot explain why the occlusion occur like that, so patchy. Yeah. Okay, next slide. So before we proceed, actually, I will do a quick revision on the ECG. So this is normal ECG. From actually this ECG, the start from your SA node to the AB node here, there will be your P wave, yeah, P wave here, yeah. Then this is called your PR interval. Okay, and then after that, you can see here, especially when you see most of the normal ECG, you can see this initial like Q-like thing, yeah. The PR, this is here, see, up the Q-like wave here. But if you go to the ST, will be V1, in the V1, there shouldn't be any Q. You know why? Why a Q wave here? Because in the septum here, this the wave, the travel is like that, yeah, from left to right. Yeah, from right to left like that. I think you know. So you put V1 here, so your V1 will be positive. So any Q in V1 is always pathological, even though it is small. Because in V1, because the wave electrical wave from from the septum here, it coming from the left, right septum here to the right. So if you put V1, V1 will be positive. But the normal ECG normally, there will be some small Q in, yes, small initial small Q followed by R and the S. And then this is the T wave. Okay. Next slide. This is QRS. Okay, next slide. So the P wave, I think you know, I don't want to describe it, present at depolarization as a duration is 0.06 to 0.12. Yeah. Okay. That will not precede the QRS, but the most important, it must be a look symmetrical like this. And it is said that it's the tall, the height is about 2 millimeter, the width about 0.08. I mean 2 boxes. Yeah, this is normal P wave. So any abnormal P waves, you should probably think of the source of atrial depolarization is not coming from the AC node. Okay, next slide. So then the PR interval, that's just now probably up from the conduction from the to the AB nodes. This here, to the AB node, then the duration is about 0.12 or to 0.20. Why this duration varies? It depends on the heart rate. If the heart rate is too fast, so the duration will be around 0.12 like that. Okay. Next slide. And then this is QRS complex, the Q, R, or the positive is always R, the negative is always Q, then after the R is always the T wave. Yeah. So the present depolarization of the ventricle, follow the interval, the duration 0.06. Yeah. So normally, yes, you will see the Q wave very small, and it is said that the Q wave is pathological when it is 25%. Yeah, of the R, yeah, 25 R, it is pathological, except in the V1, there shouldn't be any Q wave. Okay, next slide. So this is a normally the J point, actually the point mark at the end of the QRS. Actually, it is defined that the J point is where the S meet the T. Okay, the S meet the T, the beginning of the T. This is called S. This is you want to measure whether ST depression or not. We measure from the J point to the normal. Okay, then only we take whether it's ST elevation or ST depression, depend on the J point. Okay, this is okay. Next slide. Again, the T wave represent the ventricular recovery or repolarization coming from the outer to the inner, and follows by S wave. S wave, it is depolarization. The Q and R is repolarization. If the S wave is broad, yeah, meaning that QRS is broad, it means that the conduction with the myocardium is not good. Yeah, that's why they have broad QRS complex, or probably it's coming from the we call it aberrant pathway, because the left bundle branch block or right bundle branch block, or maybe the muscle is hypertrophic. Next slide, please. I don't want to discuss, on the ECG, because we had to really discuss with you, and then one day it was short about the ECG. You see, this is again an important ECG finding. Can you see? This is J point, and then any ST depression here from normal. So this is your baseline. See, the J point is there. It may be slightly, yeah. Yeah, so this is your normal baseline, normal baseline. The J point is here, yeah, okay? Where the S meet the T. Okay, this one, yeah. So this is how many millimeters. Then again here, your normal, here, the J point is here. Then you can see how many millimeters. From here, yeah, there's no J point. J point is here and here, meaning that there's no ST depression. It's more of T inversion. Agree with me, student? Hello? Student?
Yes.
Okay, sorry. Okay, next slide, please. Okay, this is how this is how you put the ECG. So V1 is here on the right side, V2, V3, V4, V6. V6 before we want to see the lateral wall, V1 to V4 to V3 want to see the anterior wall, So here we want to see the right side. This posterior wall. Sometimes we let's put this here. Yeah, ECG B7, B8. Then you get the posterior wall ECG. Okay. Next slide, please. How do you diagnose again, I think you know, yeah, lateral is ABR, V1. Yeah, the ABR, inferior, this one. Yeah, yeah, okay. Receptor, we call receptor infarction. If we want to be to the reciprocal. Reciprocal meaning that if there is ST elevation, so the repulsion will be ST depression. It should be a mirror image, mirror image between one to another, meaning the anterior, the reciprocal will be the posterior. Lateral, the reciprocal will be on the right side. Yeah. So I mean the septal, if you're talking about septal, B1, B2 ECG, reciprocal none, anterior also none. Anteroseptal, B1, B2, B3, B4, none. Lateral, 1 AVF, B5, B6. This is the reciprocal to 3 AVF, anterolateral, 1 AVF, B3, B4, B5, B6. The reciprocal to 3 AVF, inferior to 3 AVF, reciprocal 1 AVL. And I think you can more or less memorize this. Next slide, please. Okay. Now we go to the problems. So this ECG student, where is the problem? The patient presented with chest pain or colossal sudden, and then you did the ECG, it shows like this. So where is the problem, student? Hello? Hello? Student? Okay lah, you can see more or less faulty here, probably in the V2, V6, when it's slightly tall. Next slide. Okay, because of the V2, you know the coronary artery. So the LAD is anterior. So the right side is on the right. No, yeah. And then you sometimes have to point the inferior, inferior to 3 AVF down. The lateral wall is here. This is lateral. Yeah, B5, B6. So more on the circumflex, sometimes also your LAD, your diagonal. Okay.
Okay.
Okay. So what is the common management? Definitely with the chest pain in the acute syndrome, sometimes you give morphine 5 to 10%. If you give morphine, you have to give antiemetic, like metoclopramide, Aminuddin IV. You give oxygen to the patient, probably you give nitrate. You give aspirin 300%, 300 tube, and also by clopidogrel 300. Yeah. But it depends on the letter. You want to later on you will see many other drugs other than clopidogrel, pasugrel, ticagrelol. It depends whether you want to do early prime intervention or not. Okay, next slide, please. So in the case of unstable angina and STEMI, you give low molecular weight, for example, like enoxaparin. You can give heparin. Those days I give heparin, enoxaparin, or fondaparinux. This one again, you load with the 300 clopidogrel, whether you're going to give beta blocker or not, or you give nitrate to relieve the chest pain. Next slide. So again, sometimes when you have a case of unstable angina, okay, or non-STEMI, you have to score. Why? Because this unstable angina, or actually is clustered, is classified into 3 groups: high risk group, and then moderate risk group, low risk group. The high risk group, actually, you should do intervention early, yeah. Required by American College of Cardiology, you should do intervention within 11 hours. In our setting, recommended by our CPG, the ECG must be done within the index admission, meaning that you have to do the angiogram within the admission. But sometimes in the case of, for example, like in the case of cardiogenic shock, you have to do immediate primary angiogram chorus, yeah, within 2 hours, or the BP, low BP, yeah, and poor ejection fraction, you have to do early. So that's why, so some center they come up with this scoring. We call GRACE scoring. You can see here, predict 6-month mortality This score actually depends on age, heart rate, systolic blood pressure, the kidney, where the patient CCF or not, cardiac arrest on admission, or elevated cardiac marker. Any elevation of cardiac marker, meaning that non-standby is a case of high risk unstable angina. You must do angiogram within that in the admission. Other than gray score, we have TIMI score here. Yeah, risk of cardiac event within next 30 days. How they predict actually depend the age, known coronary artery disease, either the patient receive aspirin or not, severe angina, any ECG changes or elevated cardiac marker. So they're scoring there. 1, 2, 3. Okay, so that score. This one, H1 score to score like that. SO2 is more than 4. It's a high risk score. Okay. Next slide. So in the case of STEMI, time is muscle, very important. If you can do as early as you can, if you can do intervention on the spot, that better. Yeah, for example, like, because why? The reversibility, like I said to you just now, yeah, within first 1 hour, the reversibility of myocardial damage will be 100%. But after 1 hour, there will be some degree of necrosis and then some degree of myocardial damage. Yeah. So remember, in the case of STEMI, time is muscle, very important. So don't delay. You have to make a diagnosis within 10 minutes. Then from that, you conclude whether you want to give lytics or whether you want to go thrombolytic therapy or you want to do primary percutaneous intervention. So what is primary percutaneous intervention? Meaning that you bring immediately the patient to the interventional leg, then you do angiogram straight away, and then probably you suck up all the blood clots, and then you relieve the occlusion. Okay, in the case of thrombolytic therapy, the thrombolytic, for example, streptokinase, those days I think you know, but streptokinase is coming from the streptococcus. It's very cheap, about 300 ringgit. But the problem is streptokinase can cause allergic reaction, and also streptokinase actually problem you have to give infusion for 1 hour, and the streptokinase can cause low blood pressure. Another is the biocombinant streptokinase, yeah, such as altiplase and tenetplase. The problem of altiplase is slightly expensive, it's about 2,000 ringgit. Tenetplase about 5,000 ringgit per dose. But the good thing about tenetplase, you get a bolus dose followed by aspirin, followed by heparin. But altiplase, again, you have to give for 1 hour infusion. So if you want to do thrombolytic therapy at the pre-sent hospital, for example, like you want to get in, like in Australia, they give thrombolytic therapy at the site. For example, like at the clinic kesihatan, then actually they bring the patient to the center equipped with percutaneous intervention. They give at the site. I think tenetplase is the best compared to altiplase, because altiplase still requires 1 hour infusion. And also you can give beta blocker to the patient, but from the customer attire, beta blocker is not indicator if the patient has more than Kilit 1, meaning Kilit 2 and above, please don't give beta blocker. And then also you can start the patient with ACE inhibitor, for example, like this. Next slide, please. Then after that long-term management, you do ECG monitoring, especially for the first 24 hours in the CCU. Then you give aspirin, again, just now 300 milligram, the clopidogrel again 3 milligram. This one, after you discharge the patient will be on aspirin, clopidogrel, beta blocker, ACE, yeah? And then aspirin lifelong, clopidogrel for 1 hour, and the ACE and statin. And you have to modify the risk factor, okay? What is the risk factor? Actually, it's divided into 2 groups. It's modifiable or non-modifiable risk factor. Definitely non-modifiable risk factors such as age, male, sex, yeah? Male high risk than female, age, I am low risk than you. I'm joking, sorry. Okay, and then black actually is high risk compared to the whites, and the Chinese, I think, slightly better low risk than Malays and Indian, and then yeah, and the woman, and yeah, better actually compared to the men. This is unmodifiable risk factor. But the modifiable risk factor, for example, like obesity, smoking, lack of exercise, diabetes, hypertension. Some patients say, yeah, for example, like diet kind of thing, yeah. Then this one you can modify. So yeah. So after discharge, when you want to discharge the patient, you should modify this risk factor actually add back to your patient. Another thing is about your lipids, your cholesterol, LDL level also, you can be modified by giving statin. Next. So the complication, I think, the very early, the death, cardiac shock, you can ask a question letter, heart failure, and then for 72 hours, myocardial rupture, thromboembolism, and the late is after 3 days, a vertical rupture, regurgitation, cardiac tamponade, yeah, Dressler syndrome. I think you should read all this, yeah, and thromboembolism. Next. So this is a case, yeah. Okay, we do a case study, yeah. 54-year-old man, gentleman present to any with a chest pain next. ECG changes, ECG next. So 30 minutes, what will you ask the patient? Definitely you ask about the chest pain. This patient is having chest pain for 30 minutes, central, located, some location, crushing in nature, related to the jaw, and the score is about 10/10. The patient shortness of breath, look very pale, clammy, and sweating, and vomited twice. Past history of hypertension and hypercholesterol. The patient is known as diabetes and also asthma, and then high family history of acute myocardial infarction. Father died at the age of 50 due to the myocardial infarction, and then the patient has high risk behavior because he smoked about 40 cigarettes a day and drink a bottle of whiskey a week. And then she also practiced sedentary lifestyle because of the asthma. Okay, next slide, please. What are the risk factors this patient? Smoking, obesity, diet, lack of exercise. Again, I repeat to you, the cholesterol, hypertension, diabetes, age, gender, male, and family history. So next. So ECG change the student. Do you pick up anything? Student? Oh, student.
ST elevation.
Where is the ST elevation?
2-3 AVF.
Okay, what is the onset or when is the onset of chest pain? How many hours? Can you predict here? 2 hours, 4 hours? Do you see the reciprocal changes or not? B1 to B3, ST depression? Can you see?
Yes.
And then you can see the ST elevation to V4, V5. It's quite long, you know. This is dominant vessel normally. RCA with dominant vessel. Do you see the reciprocal changes at the L also? Do you see? Hello?
Yes, doctor.
Yeah, another thing you can predict the duration of the AMI. In this patient, it should be more than 4 hours. Why? Any clue? Student? There's a Q wave, yeah? First 4 hours, there shouldn't be any Q wave. Can you see Q wave here? Can you see?
Yeah.
Yeah, the Q wave, yeah? There's a Q wave already present. Actually, that chest pain is more than 4 hours already. So, okay, you have to decide whether to give it therapy or not. So this patient actually plan so after 4 hours, PCI is better than thrombolytic therapy. The first 3 hours, thrombolytic therapy is as good as primary percutaneous intervention. First 3 hours, yeah. After 3 hours, PCI is better than thrombolytic therapy. But remember, you must refer to the patient with PCI lah. If the patient does not have PCI capable, then give thrombolytic therapy. Okay, student? Understood?
Yes, understood, doctor.
Okay. Next slide. This patient actually, in this case, we know already from the ECG to 3 FDF, is on the right side. Is here. So the lesion will be on the right coronary artery. Okay. Next slide. And then from here, you can see, I want to just to tell you, probably I will repeat again. This is FMC, first medical contact. So when the ambulance here get the first medical contact, they do the ECG changes in the ambulance. Then you can see the ECG, they make a diagnosis within less than 10 minutes. Then they see this ST elevation and I. Okay, if they want to refer to a center with PCR capable, meaning that this patient admitted to the site, yeah, at site, yeah. So you can call the hospital with the capable, the PCR capable. If you can arrive at the hospital less than 120 minutes, then they can offer you primary PCI. Provided they can do the primary PCI, they can open the blood vessel within the 10 minutes, meaning that you can 120 minutes, meaning that so the time that you from 120 minutes, meaning that to the balloon, meaning we already can open 120 minutes to the balloon. 90 minutes is the hospital time here, and then 30 minutes you can 120 minutes, meaning from the time you start the ambulance to the time that we already open the vessel, it is 120 minutes. Meaning that you call the hospital, quickly they open the lab. When you arrive the hospital, quickly they bring the patient to the theater and they open immediately the vessel. But if you cannot achieve the 120 minutes, then the hospital will actually come up with another strategy. They give a thrombolytic therapy, and provided reperfusion should be given within less than 10 minutes. In the case of hospital with PCI capable, like in the UAE, we can do if the patient admitted to our ED, so we should make nowadays the recommendation is primary CPR strategy. We should open the blood vessel within 60 minutes, less than 60 minutes. Those days 90 minutes, nowadays is 60 minutes already. That's the guideline. Okay. Are you clear? Hello.
Yes, doctor.
Yes,
Okay, next slide, please. So this patient actually we opted for when we do the angiogram, opted for PCI. This is you can see the total occlusion. Sometimes we suck up the blood clots and remove and put a stent there. For example, dilation is here. Alhamdulillah, actually the patient is better, and then actually we managed to salvage the myocardium. This is the procedure more or less. Then we balloon sometimes, then we put a stent there. Next slide, please. Case number 2, and the case that patient into just now. For example, like if come to you, you want to give thrombolytic therapy, sometimes you have to do a diagnosis. For example, like you want to know how bad is the injury actually, and then okay, you should do further test. For example, like cardiac marker, you did ECG just now. Then you can see the cardiac marker here. Myoglobin is not very specific. It is very general. CK also not very specific. LDH is not very specific. This one is will be increased in all muscle. CK, LDH, and myoglobin. CKMB and troponin T actually very specific to the myocardium. You can see here, for example, that here. Normally it was peak here. You can see here CKMB within half an hour, and then within 2 hours it will diminish. You can see here. That's why if about half an hour you're going to do CKMB is elevated, then you can say this is some myocardial injury. In the case of troponin I, can see, or troponin T, you see here, troponin I, troponin T peak, close to 1 hour, but like that, and then after that it's a diminution, after up to 14 days. So that is the troponin will be present up to 14 days. In the case of troponin I, T is sometimes about 8 days kind of thing. So very important. For example, if the patient come too early, for example, like 15 minutes, 20 minutes, then there won't be any cardiac biomarker elevation. Okay, next slide. So if you think this patient is a case of non-STEMI or unstable angina, depend on the biochemical marker just now, then you can decide whether you want to get anacetrine or fondaparinux, and then you can give clopidogrel, beta blocker, nitrate, essential. there's no thrombolytic therapy or no primary percutaneous intervention. But in the case of high-risk unstable angina or non-STEMI, we do early percutaneous intervention. Okay? Next slide. This is another chest pain that I want you to see. This is more or less ST depression. You can get the J point is here, that the baseline is 2, definitely this ST depression. Agree with me, student? ST depression, right?
Yes.
Yes. Okay, next slide. Okay. Sometimes you can, if for example, like you have this kind of ECG, anteriorly, sometimes it may be due to posterior myocardial infarction, then you can do posterior ECG in this case. Yeah, you look at the back, yeah, V7, V8, V9, and then you can see some ST elevation changes there. Okay, so next slide. So you look at the V1 to V3 where the ST elevation. Next slide, see. So here, there's some degree observation. Yeah, posterior ECG. Okay, next slide. So even though the patient has ST depression just now, still can be posterior MI, you have to do posterior ECG. So this is when you do the angiogram, you see. Normally there will be a blood vessel like this, you know, the blood vessel like this, yeah. This is a circumflex. From here to here, already 100% blocked. Then the water and the dye flow to the blood vessel. Okay. So this is a this is a case of EMI. Then you can see like this, nothing here, or just a stump. No dye flow to the blood vessel. Okay. Next slide. Again, what do you see here? Acute chest pain. So then, one ABL. You can see one ABL elevation.
Yes.
So what sort of AMI here? One ABL posterior. Yeah. Okay, come next slide. So sometimes you give a thrombolytic therapy. The patient be to the opted, opted for the thrombolytic therapy. You do serial ECG, for example, like 30 minutes at 1 hour. The best actually you want to look at the 90 minutes. If the ECG shows resolution, meaning that the ST elevation is reduced in terms of the height of the ST elevation reduced by more than 50%, and clinically the patient is better, it means that the thrombolytic therapy is successful. Okay, student? You got what I said just now?
Yes, sir.
Yeah, so if you opted for the thrombolytic therapy, you have to assess whether your thrombolytic therapy is successful or not. How do you assess? You do ECG at 90 minutes. If the ST elevation decrease more than 50%, yeah, and the symptom of the patient is better in terms of BP, blood pressure, chest pain, then it is said that this patient, you have a successful thrombolysis therapy. Okay. Next slide. Sometimes the patient can have atypical eloquent presentation, for example, like like in this patient, LBB. LBB is difficult for you to diagnose whether the patient has AMI or not. Sometimes the patient presents with the LBB, yeah, and then with the chest pain, you don't know whether this is LBB with myocardial infarction or not. Then this criteria actually can be used to improve the diagnosis accuracy of STEMI in LBB. This I want to tell you. Yeah, this you have to memorize this. Yeah, there's the correct Saragossa criteria to diagnose. That is just what I want to highlight to you. Sometimes not all patients will present with typical ECG changes, especially in the LBB. You can't see an ST elevation. Okay, next slide. Another thing is isolated posterior MI, like just now, for example, like sometimes they have this ST depression more than 0.5 millimeter in the V1 to V3. That you have to do the posterior chest lead, at the V7 like just now, V7 to V9, you can see the ST elevation. because at the posterior, yeah, at posterior part of the heart. Another thing is maybe this indicate to you as elevation in the AVR, probably not always true. It shows that probably the patient left main occlusion is what spread as horizontal ST depression, then or estimation in VR more than 1 millimeter, estimation in AVR in and also in the V1, more than V1. Next slide. Okay, sometimes 30-year-old with chest pain present with pulmonary edema. What happened to the patient here? Student? ST, yeah? AVR is high. Can you see AVR high? Here?
Yes.
Yeah. AVR like this can be a wrong lead. You have to check your lead before you see it is an up AVR. But this one estimation AVR, maybe the patient has occlusion in the left main. Yeah, if you don't do anything, this one very, the patient can die within 10 minutes, 10 to 20 minutes. Yeah. Okay. Next slide. Okay, this is echo. Sometimes it will help you. It should be tally, could be commensurate. Yeah. If you have the LAD territory that shows also akinetic movement of that particular area. Yeah. The LAD territory myocardial movement. Yeah. So it must be tally. Then only you can. Then only echo will help you whether this patient has acute myocardial infarction or not. Next slide. So again, yeah, step to approach ECG in the ACS, appropriate clinical presentation. I recapitulate again. Then after that, you STE, right, contagious leak, you think of AMI, yeah, this in the contagious leak, and the corresponding to the territory, and look for the reciprocal. Sometimes you can look for the duration on the also, yeah, in the presence of Q wave. The Q wave more than 4 hours. Yeah, the step 3, look at the T wave, maybe tall T wave is early AMI. Then you look at the QRS complex, maybe the onset LBDB. Then you have to be careful with the chest pain, maybe the patient AMI, because you won't see any ST elevation in the case LBDB. And then you also want to see the dynamic changes on ECG. For example, like if the patient present with unstable angina or non-STEMI, if the ECG is dynamic means sometimes as the depression 2 deep, 1 millimeter, 2 millimeters, and normal. It means that the clot is labile. That's why the ECG is dynamic. That is very dangerous, and at any time the patient probably can have heart attack, acute myocardial infarction. That you have to probably has to bring the patient early to the lab to do angiogram. Next slide, please. Okay, this one I just recapitulate again. It's our first medical contact. It's very important for you to know. Refer hospital, emergency department, ambulance. Okay, next slide, please. So again, first medical contact. This again, I repeat the ECG just now. The slide just now. Very important for you if in the heart side, yeah. Just now, when you have a side. Very important for you to decide early, do ECG within 10 minutes. If it is MI, they used to decide when they want to treat and give something over there, clopidogrel or aspirin. In Australia, they can give lipid therapy in the ambulance. Yeah, here we don't have that facilities yet. Okay, then you have to decide whether you want to send the patient to the hospital capable PCI, or maybe you want to give thrombolytic therapy. It depends on the time. Time is very important. Okay, next slide. I think this is very important, the relationship of pre-hospital care and STEMI. You can see here. Yeah, it improve mortality by 17%. Next slide, please. Okay, next slide, So, okay. So you have to give oxygen. This is another evidence. Oxygen you must give if the oxygen is low. Don't routinely give oxygen if the saturation is more than 90%. Okay, next slide. Okay. Okay, this is within 3 hours, like I said to you, primary PCI and then percutaneous intervention the first 3 hours. The success rate is the same, but the problem of lytic therapy is intracranial bleeding. That's why in the Europe, Normally 100% they will do primary PCR regardless of 12 hours or up to 24 hours, they do primary PCR. Okay, next slide. This again, the strategy you have to decide. Next slide. Okay, I think I repeat this again. Yeah, antiplatelet therapy given the first medical contact, you can opt for. Just now, sorry, I opted for ticagrelor if you decide to do percutaneous intervention. Yeah, ticagrelor is like clopidogrel. Yeah, so they act on that pathway. Okay, next slide. Next slide. Okay, this is all the evidence. Yeah. Clarity trial, you can add clopidogrel, Atlantic trial, yeah, these are the trial. If you, for example, yeah, want to be a cardiologist, you have to remember all this trial. Next slide. Okay, all the evidence. I think I stop here. Any questions, student? Student? Any question? Anything that you are not clear? Hello? Can I hear you?
Yes, we can hear you.
Okay. Clear or not clear? Confused? Student?
Yes, yes, Doctor.
You clear?
Clear, Doctor.
Yes, me clear or not sure? Hello?
Clear,
Clear
Doctor, clear.
and wait for the reading.
Huh? Any question?
Doctor,
Uh-huh.
I have a question. For example, if the patient undergone thrombolysis and it is not successful, and the patient is not near the PCI center, so what do we do next?
Oh, okay. Here the patient center, because when you give a thrombolytic therapy, you divide it into two groups, yeah. One we call it unsuccessful thrombolytic therapy, right? The second one will be, we call it recurrent myocardial infarction. Initially it's successful, now recur back. You have two conditions, right? If, for example, that the patient has recurrent AMI, sometimes you can repeat thrombolytic therapy, which can cause bleeding. Or if unsuccessful thrombolytic therapy, you have to refer to a center because, you know, we will do the PCR within 12 hours, 12 to 24 hours, you know. Okay, we still attend, okay? I think in Malaysia, even though, and I think you can reach the hospital with capable PCR within 12 hours, I think you can reach the hospital, right? Meaning that you have to refer to the hospital, which can do PCR within 12 to 24 hours. Okay. Hello?
Thank you.
Okay. Question? Student? No question?
And Doctor, I have a question. If the patient come to hospital within less than 30 minutes, and there will be no cardiac changes and ECG changes, right? So in this kind of patients, do we treat it as an unstable angina, and we do a ECG serial ECG 15 minutes until
This is very important question. You have to balance between the myocardial survival. If you late in making diagnosis of STEMI, there was some degree of myocardial damage. It depends on the symptoms. The patient is very severe chest pain. Then you do echo shows. You have to do echo shows akinetic. Then you treat the patient has EMI. This is the decision must be done by a specialist, yeah. Because you have to treat as EMI. In American call it a cardiologist said, yeah. If you are happen to be in the hospital with PCR capable, you can do angiogram straight away to see whether this is AMI or not. If you have CT angiogram, which can be done within 10 minutes, you can do CT angiogram to see the plaque burden. And then the issues whether if you are at the hospital with the PCI capable, whether you want to start thrombolytic therapy, the specialist should discuss with the patient about pro and con of giving the thrombolytic therapy. Actually, I have the slide about pro and con, the contraindication for thrombolytic therapy. Yeah, in this slide also actually, I can show to you kalau you want to see. And then if the patient agree for thrombolytic therapy, then you proceed with the thrombolytic therapy. If the patient disagree, then you treat as a unstable angina. Then you keep monitoring the patient. Okay. Everything is actually you have to discuss with the patient, the option, and if the patient requests to be transferred to another hospital, then you transfer the patient. Okay.
Okay, Doctor. Thank you. Understood.
Okay. Okay. This is the output contraindication for therapy. Okay. Any questions, student? Are you comfortable to manage acute coronary syndrome, student? Hello?
Not yet, maybe.
Not yet. Why? Any reason? Aziz?
Because sometimes based on theory, we might have to complete, but experience-wise, because confidence.
You are year 3 or year 5?
Year 5.
Year 5, my goodness. You are going to be a doctor, you know.
Yes.
You have to clock a case, clock, then chest pain, then you divide whether it is what is the cause. Do ECG. Okay?
Okay, then.
Any question? If not, I will end the session here. You can read my slide actually with the contraindication for therapy. As you know, this one actually you can read, and then you can read my slide. I don't want to discuss this because this is just a template that you have to follow. Okay. Any question?
Doctor, we have question in the chat box. If the time to balloon is more than 120 minutes,
then you cannot do. Yeah, you must opt for thrombolytic therapy. Opt for thrombolytic, given lytic, yeah. Hello.
Okay, doctor. Regardless if the onset of AMI is more than 3 hours, still thrombolytic therapy.
Yes. Because time is very important. The concept is to open the blood vessel. It's not the method, yeah. Then after that, if you have choices, then you definitely you go to the safer choices. Okay. Okay.
Okay, doctor.
Okay. Okay. Anything? Any question? Chat box. Okay. Here. Thank you. Thank you to everyone. Thank you. Okay. If no question, I end the talk here. Is that okay? Or you have question? Burning question? Last question? I like question, you know. Yeah, Adaha, Anis. Do you have a question? Hello?
No question, Doctor, for now. But I believe if we have any question after this, we will reach you.
Okay. This one other chat box. Prof. Thrombolytic prefer. Okay, then I already answered the question already. Okay. If no question, thank you very much. Actually, yeah, I'll get back to you again, Madam Chairman.
Okay. That's all for today's session. So thank you, Doctor, for good enlightenment from you. So with that, we close our session with Surah Al-Az and Tasbih Kafarah. Okay, thank you, Doctor.
Okay, thank you.
Thank you, Doctor.
Thank you, Prof.
Okay, thank you.
Thank you, Prof.
Thank you, Prof.